Thank you so much. I believe that we do have a quorum, although we will take a roll call vote.
This meeting is being recorded.
Excellent. So at this time, we're going to call to order the Monday, August 30th, 2021 special meeting of the Naturopathic Medical Committee. And Rebecca, would you mind doing a roll call?
Great, thank you. All right, Dr. Thompson? Dr. David?
Present.
Dr. Yoon?
Present.
And Ms. Worrell?
Present.
Wonderful, thank you. We've got, I don't believe we have Dr. Quinn online, but I'll call him also. Dr. Quinn? Okay. All right, looks like we have a quorum with 6.
Wonderful. Thank you so much. So at this point, I would like to call our meeting to order. The second item on our agenda is for public comment of items not on the agenda.
And shall I open up the public comment feature of WebEx?
Yes, please. Thank you.
Perfect. So members of the public can indicate that they'd like to make a comment by clicking on the icon with the question mark within a square located at the bottom right-hand corner of your WebEx screen. These instructions that are on the screen now will be shared each time for your reference. In the Ask field, typically in the lower right-hand corner of your WebEx screen, members of the public can type, "I would like to make a public comment," or just the word comment, and send it to all panelists. I will take comments in the order they are received. I'll call on the member of the public and request for them to unmute their microphone. They will then have 3 minutes to make their comments, and I will provide a 30-second warning. At the conclusion of the time, the microphone will be muted and we'll move on to the next member of the public who has a comment. At this point, I do not see any requests for public comment. Shall I close the feature?
Please do. Thank you.
You're welcome.
Okay. So the next item on our agenda is an update on the regulation packet for AB 2138, the substantive relationship and rehabilitation criteria. Rebecca, would you like to give us any updates on this?
Absolutely, thank you so much. Can you go to the next item, or next slide, please? Thank you. So I'm happy to report that AB 2138, the Substantial Relationship and Rehabilitation Criteria Regulations Package, that made changes to Title 16 of the California Code of Regulations, Section 4256, 4258, and 4259, was approved by the Office of Administrative Law pursuant to Section 11349.3 of the Government Code and became effective on August 4th, 2021. A copy of the approved package can be found on our website under the Approved Regulations section. This was a really big package and we worked really long and hard on it, so I just wanted to let you guys know that it is done. Do you have any questions?
Thank you so much.
No problem, thank you.
For all your hard work. Sorry, I think we both spoke at once. Thank you, Rebecca, for all your hard work on that. Does anyone have any questions or comments regarding this packet or its where it is at? Regulatory process? At this point, I would like to call for any public comment on this agenda item. And Moderator, have you opened for public comment?
Yes, the Q&A feature is now open. Any member of the public who would like to make a comment can click in the ask field and say comment, or I would like to make a comment, and we will take people in the order that they were received. And I see no requests for comment. Shall I close the feature?
Yes, please. Thank you.
You're welcome.
So the next agenda item is the majority of what we need to speak about during this meeting, which is agenda item 4, discussion and possible action on IV advanced injection therapy requirements. This was had several edits from, I think it was from legal. Is that right, Rebecca?
That is correct. We had some suggestions from legal, correct?
Right, that need to be approved. So there was some change in text, and then there were a couple of other edits that were noticed by members. So we need to discuss all of those and try and approve final language on this these regulations. Thank you. So, Rick, I'm going to let you show the items here and what we're looking at as far as changes.
Great, thank you. And I'm going to go ahead and welcome Karen Halbo, who is our regulatory counsel. She's with DCA's Legal Affairs Division. And Karen, are you with us this morning?
Yes, I am. I was trying to get to the right button to unmute. Thank you.
No worries. Thank you for being with us today.
Let's see.
So I just wanted, Karen, to kind of provide an update for you guys. And as you can see, we have the memorandum that went out to all of our members of our committee. And this is just kind of giving you an outline of what exactly happened and why these edits are being suggested. So Karen, I'll let you go ahead and take this.
Yeah, the regulations unit has a new lead attorney who has 20 years experience working with DCA in the legal office, and she does a great job with these things and pointed out to me, well, there are these some authority issues, and here's what we need to do to try to address it. And that's what's been put together and explained to you in the memo. And I am delighted to see that the committee's looked these things over carefully and had other suggestions to differentiate injection therapy that we're talking about a more specialized level than what you normally have. All just going through carefully and making changes is a great part of getting the regulations in shape. You've had some time to look over that. I'd be happy to answer any questions. I do not believe in reading memos aloud to people. You had time to read them, and I know you can all read well. So, and you have some additional matters and improvements that were suggested. So what I would ask is, does the board have questions? And Rebecca, I know you had some additional slides. I thought I was so pleased to see this kind of careful review by the committee. It really helps in the regulations process.
No problem at all. So yes, there were some concerns that we didn't have some authority to put forth the regulation text as we had originally put it out there. So what Karen did was they made some changes to the regulatory, well, let me see, hold on, I'm trying to get to that page really quick. So there were some changes made to the 3640.7. Hold on one second, I'm sorry. 3640.8 is the requirements stating what we're allowed to have the licensees take in terms of IV therapy requirements. So there were some changes that were made, and you guys had taken a look at this, and it basically just added what we would like to see in the training requirement. And then there were also a couple of changes made to, let me see here, 4237.1, the training requirement for the IV therapy course. So I'm going to go ahead and go. Were there any questions on any of the language that was sent out to you guys? Okay.
This
so
is
let me go ahead. I'm sorry, go ahead.
This is Dr. D'Amico. Are you talking about the language of the memo or the language of the IV stuff?
Yes, the language of the memo and the IV language that we sent out. And I know that you had some concerns, and we're going to go through those in a few moments. I was just the language that was originally sent out.
Okay.
So at this point, we're referring to the changes in the language pertaining to what courses can be used for certification. Is that correct?
That is correct, yes.
Does this make any functional differences in what we, I mean, that was actually a question for me when I read over it. Does this actually change anything functionally as far as what we had put forward as the requirements? Because I didn't see anything that changed anything substantial in our intent as far as people being certified, having those courses approved appropriately, etc. The one thing that we had talked about, which I think is important, is to change the training requirements so that it matches up with our licensure cycle, which I think was a very good catch on your part.
Right. So yeah, we're going through this, and I know that some of the language, like I believe Greta had brought up that about the advanced or specialized injection therapy instead of just saying injection therapy. That way, you know, we're not requiring them to add training for basic stuff that you guys are already learning in the naturopathic colleges. So this is just the advanced stuff that maybe you would learn after the fact. So the section 4237.1, this was prior to the meeting. The committee members asked for some of these items to be looked at, clarified, edited, or added. Section 4237.1, these proposed regulatory changes do not apply to basic intramuscular, intradermal, or subcutaneous injections of medications and nutrients, such as administering a B12 shot, that are part of the basic medical training of all naturopathic doctors.
So this is Dr. D'Amico. Are you proposing to add this, or are we clarifying? Because when you read 4237.1a, it says in order to perform IV or injection therapies, a naturopathic doctor must pass a qualifying course on IV therapy. And so it doesn't say the injection therapies mentioned in another section. It
Right.
just says injection therapies.
Thank you for
So
going to the next slide. So if you take a look at the next slide, we actually asked that the currently using the term injection therapies, that the term should be changed throughout these regulations, that they be either advanced or specialized injection therapies. And that came from your suggestion, Dr. D'Amico.
And I might actually say to, as it is elsewhere in the document, to refer to the items listed and use the section number so that it's very specific to those particular things that are listed in the regulation.
Yes.
And the other thing about that particular A, 4237A, is it's saying that, and I just want to make sure this is the intention, that to do those specific injection therapies, you have to have passed a course on IV therapy.
That is correct, yes.
So if you want to do microneedling, you have to be trained in IV therapy?
No, I'm sorry, that would be advanced injection.
Well, but microneedling is listed elsewhere as an advanced, as one of these items. That's what's discussed in this regulation.
I understand what you're saying, Greta, and I do believe that is still the intention. I understand your concern there, but the idea being that if people are doing what we consider the advanced injection therapies, they should have certification in basic IV therapy, which includes several safety and emergency type.
Okay. I'm just making sure that was intentional.
That was intentional, yes.
Okay.
However, we did want to very clearly differentiate that from, the basic subcutaneous and intramuscular injections that every naturopathic doctor is trained in school, and indeed has to be able to demonstrate competency in order to graduate. So we don't want to require people to do advanced therapies in order to do a B12 or a magnesium shot, because that's something that they are trained in as part of their basic education.
Yeah, and I just want to say, I'm just going to state this, that, I looked it up and I can buy a microneedling pen at Walmart and do it at home on myself with no training.
But we do not recommend that you do.
I know. I'm just saying it's an over-the-counter, readily available thing available to any person to do on themselves. It's great that we should have the training, but yeah, hopefully people recognize the value of that.
I think that having someone who's appropriately trained and certified is of significant value to consumers and also to their safety.
Yeah. I'm just gonna say this as part of the discussion, and I will let it go. But estheticians also do this more than naturopathic doctors. This microneedling, and they don't have to study all of these formulas for IV therapy and calculate osmolarity and take tests. I mean, it's a kind of it's to me that's an education that doesn't apply specifically to that technique.
Yeah, I mean, I definitely understand your concerns, and I would be interested if other members have a comment on this as well. But again, I think that there are a lot of things that are being done in the general public that are not for the best interest. And there have been concerning issues around patient safety that have arisen in clinics where untrained estheticians, et cetera, are using microneedling. I think our intention here is to say that if you are a licensee, we want you operating at a specific level that is for the safety of the general public. But I don't want to be dictating things here. This is my opinion. So if other people have other
You're kind of
just so you guys are aware, there's currently I would say there's roughly between 65 and 70% of our licensees that have already had IV therapy at one point. So the amount of licensees that already take IV therapy just coming straight out of Bastyr and UNM, or that have went and taken the course after the fact is quite large. So I don't know that we are asking more than what's already kind of being done. And these folks are going and taking these courses without any requirement being needed or being requested by us at this time, except for what's already in our statute. So I think that they're going to take the IV therapy anyway, because here in California it's a big part of the treatment in a lot of our ND's practices.
That's a good point, that they're getting it now in school anyway. Thank you.
Yeah.
So we're proposing to somehow change the language from a general quote injection therapies in subsection A to the injection therapies listed in 4237 2 3 through, well, basically 4732 37.2. Is that correct?
Yes, so anywhere that that currently says injection therapies, we will make that change to advanced injection therapies or specialized, whichever one you guys feel is a better descriptive.
So it's a kind of a legal question for me in terms of interpretation. If we say advanced, does that leave room for it to be defined otherwise, or do we need to specifically define what we mean by advanced? Or can we just refer to the section that refer to the section that lists what we're talking about as advanced?
I think this is Karen Halbo, the Regulations Counsel, and certainly the Office of Administrative Law would prefer the more specific to refer to the section of those listed, but then that limits those therapies to being the things you need to have additional education for in order to be able to administer. My exposure, I've come on to this board in the last few years, and I've looked back at the meetings of the IV and Injection Therapy Committee, and I know they worked very hard on this, and I feel like people who were on that committee should be answering your question because they've really chewed through this before. But at least that's the specific answer. I think you're correct. You're saying, shouldn't we be more specific? And that's quite entirely what is the board trying to do? You know, are you trying to say these are the ones that you have to get education for? Or are you trying to say anything advanced, not knowing there might be something that is developed as advanced in the next few years that is not taught in school that somebody might get trained in? I don't know the field well enough to know.
Karen, this is Rebecca. You're hitting it right on the head. And when we were going through these subcommittee meetings with IV therapy and the advanced injections, that's exactly what our thought was. I know that the committee members that worked on this language, we've really tossed that back and forth whether we should actually put those specialized or advanced injection treatments in here, but then what if something new comes out, in a couple of months, then you guys are not able to do it until we do another regulation package. And as you can see how long it normally takes, anywhere from, 12 to 18 months to get a regulation, you guys would be, prohibited from doing those things. So we wanted to keep it somewhat broad, but specific enough that any licensee that's coming out of the school or that is coming to California is going to know what a specialized or advanced injection therapy would be. It's going to be something that was not covered in school, and it's going to be something that you actually have to go and get, additional training for. So PRP, any of that kind of stuff. So this was brought up.
Sorry, this is Dr. Thompson, and I actually was on this committee. So I think I can comment a little bit to that. It was my understanding, and I'm sorry, I would have to go back and read the entire packet in detail to find this section, but that we had put in a stipulation in this packet that said specifically that we may be able to add other advanced therapies as a committee as they came into use. So if that is indeed the case, and again, I'm sorry that I can't go through and find that answer that specific question in real time right here, but if that is the case, can we not refer to the section to be specific, like we're only talking about advanced therapies in this particular, as listed in this particular section, but there's a stipulation elsewhere in the regulations saying that we may add things to that section as become necessary. Am I remembering this correctly?
Yes, and that would be in section 4237.2, if you go down for the injection therapy courses in 3, 4, and I believe 5, section 3, 4, and 5, that's where it's listed for the PRP, for the microneedling, and I believe, let's see here.
Ozone.
Yeah, for the ozone. So it is specific, but it's broad enough to where if something is added to these type of treatments, it's not going to restrict our licensees from being able to do it as long as they've got the appropriate training.
Right now, as I read it, the only advanced injection therapies that we're requiring advanced training for are the ones listed. And I guess my question is, how difficult is it going to be for us to add things that if some new therapy that requires a different set of training is available? There's a section here that already has a provision for people learning about new general infections. That's for recertification, right? So we're requiring doctors to do a recertification in either their specialized therapies or basic IV therapy every 6 years. We had originally said 5, and Rebecca pointed out that that's not going to work very well. These are people's licensure cycles, so we'll have to decide as a committee if we can move that to 6 or 4, although I think 6 makes a little more sense. That being said, there's a provision in here when you look at the requirements for IV therapy saying that part of the reason we're asking for recertification is so that people can learn about new injectables and admixtures, et cetera, so that they're up to date. So that's there already. So the only thing we're really discussing in this situation is what happens if some new and different type of injection therapy that's not listed here becomes available, and I even might think of an example right now because it's not something that exists or it would be in the packet, but and we feel like we need to specify that our licensees have to be trained in that. Is that something where we have to rewrite a whole new regulation, or that we have the ability as a committee to simply add that as needed? That's my question.
Well, as a matter of law, you would simply amend this existing regulation once this is adopted to add another section. So you would add in a 6 explaining the new therapy and specifying what other education must be involved. But the Office of Administrative Law doesn't allow a board to leave a big open space in which they can just specify new things as they come on the market without going through the regulation process. So, however, I am full of hope that the regulation process is going to be faster and faster because there is now a regulations unit of attorneys that are helping. If the board is going to add new training and specify, this many hours of training in a particular new therapy, that's going to have to be by regulation. Yeah, I understand the idea of kind of trying to leave the barn door open a little bit, but the kind of goal of the Office of Administrative Law is that new regulations are clear and specific, and that it's not, it doesn't give the government broad power to change its mind without going through the airing it out regulations process, because the public is invited to comment on the regulations.
Absolutely, but if I understand what you're saying, it would be an amendment to the section. And so if we change the language to say, as Dr. D'Amico had stated, only the advanced injection therapies as listed in this section, and if we amended it, we would simply add something to that section and the language would still hold appropriately. Is that right?
Yeah, you'd do an amendment to that section you know, what you're raising here is basically a clarity issue in that will the Office of Administrative Law say, well, what does it mean by advanced or what was the exact phrasing she had, or specialized injection therapies? That's not defined within the regulation. So specifying an advanced injection therapy as spelled out in 4237.2, that one's guaranteed to be seen clear enough by OAL, and using the more general language, frankly, makes my job harder. But boards do different things. And because OAL, their standards change over time, and they are looking much more closely at regulations and requiring a great deal of specificity, so that the fact that you might see sort of more general language within the California Code of Regulations for another board doesn't mean we can get that through now.
Hey.
So,
Karen, this is Rebecca. What if we were to add a definition of advanced injections to section 4206 under our definitions in the CCR?
Yes, that would be good, because then when you say advanced injection therapy as defined in, and point to the definition section.
This is Dr. D'Amico. We're referring to the same thing in two different ways. In the first part, 4237.1, we just say injection therapies. In the second part, we say 4237.2, we say injection therapies outlined in subsection B, which is really specific. So if we just repeated that in 4237.1, the injection therapies outlined in section B of 4237.2, it would be very consistent. If there's a reason that we want to add the word advanced for clarity of other people who might read this to explain the intent, that's great. But it would be doing, by adding a definition and then referring to that definition, the definition is still going to refer to subsection B. So it's just adding more language, to do the same thing.
Right.
Yeah, I think you should apply Occam's razor and do the simplest, which is what you just described.
I think Dr. Yoon has a question.
Yeah, so I am because I want to go back to what Dr. D'Amico had mentioned regarding the microneedling and the PRP. So the way that I'm understanding this is that if you're only doing microneedling or PRP, then you do actually need to do the IV training, which part of the argument is that most graduates are now having the IV training within their education currently. But the way that it's written is that they're going to have to training every 4 to 6 years thereafter. Even though they're not doing IV training, they're doing microneedling or PRP. And then on the third section, they're also required to have everything that you need to have for the IV therapies and the advanced injections, which include things like epinephrine, the backboard, the oxygen, the defibrillator, if you're doing microneedling and PRP. Is that how I'm reading it?
That is an accurate reading of the current regulatory package.
Okay, because I think I'm in disagreement for that, because I think that needs to be the advanced ejection therapies then should be separate, because there's a big difference between chelation IV therapies and doing microneedling.
So yeah, I definitely understand that argument. It's unfortunate that we're having this discussion right now. So in order to make that level of change in the regulation. I think we're going to have to go back and do some significant rewriting. And of course, we want to make sure that we're regulating our licensees appropriately. And if we need to make that change, then we do. I do want to also just close the loop on something that Dr. D'Amico said regarding the wording on what we're saying is advanced injection therapies, etc. So I think that I am trepidatious about adding a definition to the other section as Rebecca was referring to, and I think that keeping it such that it is only referring to the advanced injection therapies in that particular section leaves less room for misinterpretation, because what we don't want to do is put our licensees in an ambiguous area where someone could come along and say, well, you were doing some sort of advanced therapy that you weren't trained in and you should have had advanced training, but we don't have something set up for them that says this is the exact advanced training you should do. So I think if something like that comes up, we have to add it and be specific. We can't leave a situation where our licensees their actions could be misinterpreted as not following the law because we left something ambivalent. Does that make sense?
Yes.
So if we specify that section, then if something comes along that we feel like they need more specific training in, then we have to add an amendment to it that includes that. But we don't have someone coming along and saying, well, you weren't specifically trained to use, I'm trying to think of some newer injectable like, NAC in school, and therefore shouldn't have been using it in practice. There's just I think it's too fraught with potential complications. So I do like Dr. D'Amico said about referring to the specific section. I think it's better. And it doesn't, and as I read it, it doesn't mean that they can't do other advanced therapies. It means they can, unless we come along and say that therapy is such that we have decided that you need this other specialized training in addition to what you already have. Does that make sense?
So we're proposing changing the language in 4237.1A to read, in order to perform intravenous IV and or the injection therapies outlined in section 4237.2 subsection B, comma, and the rest of it is the same.
I guess I would ask that you use the term described versus outlined. That's just worked better.
Describe.
And then
I'm sorry, Greta, which section is this?
So 4237.1 at the top, training requirements. So section A, in order to perform IV, intravenous, and or the injection therapies described in section 4237.2 subsection B, comma, and the rest is the same.
Okay.
And then with that, we're also proposing that we change 4237.2 subsection A to read, in order to perform injection therapies described, not outlined, in subsection B.
And you would also change back in 4237.1 under C and D, when it's the underlined language, IV and the injection therapies described in section 4237.2 subdivision B, so that it's clear that's the same thing we're talking about in A and C and D.
Excellent.
Perfect. Okay. I've notated those changes.
So now we still have the issue of microneedling. And Dr. Yun, can you clarify when you're talking about, you know, disagreeing with PRP being included in here, are you talking about using PRP specifically for microneedling or in other contexts? Because there are two sections here. There's a PRP section and then there's a microneedling section that specifies that if you're using PRP and microneedling, you need to saying the proper use of PRP as well. So is it PRP in general or is it in microneedling?
Yeah, and just so that you know, Dr. Thompson, you're fading a little bit in and out. I don't know if it's only for me or if other people hear that as well. Just wanted you to know. So yeah, usually together when you do microneedling and the PRP, those two in combination. If you're doing PRP as an injectable, I could see that as being maybe left in there, but also more specific, right? Because PRP can be done topically after microneedling versus injected.
And I'll just say for the sake of our discussion that PRP is actually a blood product, which we're already approved to inject under our current law.
So is that something that is taught in the naturopathic colleges right now?
No, this is Dr. Singleton.
Okay.
So, and just to add in, and having done PRP training and having IV therapy, the content is not the same. So I feel like it's, and being on the subcommittee, I feel like my understanding was there's a separate piece for education around PRP, specifically around microneedling, and that's its own specific education requirement, separate from IV therapy. Because in using PRP and preparing it, the contents are completely different than IV therapy, completely different.
So the training and the equipment that you need in the clinic, right? So
it's completely different.
Needs to be, you know, split too on the section 3.3.
Yes, it's completely different. The tools used, the equipment used, the only thing that it really has in common is using needles. That's it.
I think the question is, this refers mainly to the emergency medicine section of this regulation, which is what you're required to have in the office for patient safety if you're performing these therapies. And so I think what we're asking here is which of these go across every section, and are there certain things that are not necessary if you're doing specific therapies? So in microneedling, do you really need to have epinephrine in the office? I guess that sort of question. Am I understanding it correctly?
Yeah, I think that I'm trying to think of the components that are used. If a person is reactive to, let's say, if there's a topical anesthesia that's used against lidocaine or any other anesthetic, then yes. But I think in terms of the actual procedure of microneedling, could a person go vasovagal? Yes. Could they go vasovagal on getting the blood draw for preparing PRP? Yes. So I think anything that would be used for a obtaining a blood draw for standard lab procedures would suffice for PRP.
I think that's a good principle to look at is, do these actions constitute a higher risk than other things already allowed without specific regulation?
So PRP does involve the use of an anticoagulant medication in the tube. So do you think there's, and because it's going to be injected, there is the potential for allergic reaction, even though it's not going intravenous. So that is something when we're looking at the things that need to be used for safety, anything that would deal with anaphylaxis, I think still needs to be present.
Mm-hmm.
That could be true, though, if we're with an essential oil. It could be true with a topical application of anything. It could be true with, other things that we do.
Yeah, I agree. And I think that, as doctors, we should have things to deal with basic medical emergencies in our office regardless.
And that is already part of our training, to be aware of that and to be prepared for that. But if this does constitute higher risk than what would normally be covered by our awareness and our training, then we should regulate it.
So, Rebecca, I think that when we originally put this this packet together, one of the things that we talked about was what are the things that are coming up and we're getting a lot of questions about and we're getting a lot of safety about. And, I'm realizing now in this discussion that sort of our emergency medicine information was painted with a broad brush here. So I'm wondering if the IV therapy committee needs to go back and look at those safety and emergency medicine requirements and see if they need to be differentiated for some of these specialized therapies.
Sure. So what we can do is we can take a look at the 4237.3, which is the office requirements for all of the safety items, and then go and look at the 4237.2 section B, number 3, 4, and 5, and determine if we need something different for those items, since those are specifically kind of in their own little sections in here. But we can definitely do that. We can do another subcommittee meeting, look at this list in 4237.3, and then come back. And if any of the parties, members of our committee, have items that they would like to add, they can send that stuff to us so that we have that moving forward in the 42 when we're looking at 4237.3.
I believe it's already understood, my understanding of our current law, that, we are to practice within our scope and that there are other things we're allowed to do, but it's understood that we would get training to do them if we weren't trained in school. And that's kind of just an overall principle of applying that law. And so we don't necessarily have to address every possible thing that someone might learn after they graduate. Given that the education is meant to be a basic education to help you learn how to not hurt people and to be basically functional as a primary care doctor, understanding that we all, we have very big continuing education requirements, and we're going to move into different specialties in different areas as we grow. So again, for me, the question is a question of risk and protection of the consumer. And so I think maybe what Dr. Thompson was alluding to is, are you seeing a lot of complaints or negligence or malfeasance on the part of doctors, specifically regarding these therapies, which are done by estheticians, are done by people, not the PRP, but the microneedling, are done by people, just getting over the counter devices and doing it at home. So are you seeing that the doctors are really endangering people with these things? We don't know the answer to that. Maybe you do.
So I haven't received any specific complaints about those type of things. I can tell you back in 2016, we did have an issue where there was no crash cart in a facility that was doing IV therapy. So there are concerns about that. And, you know, if it's not in black and white, there are some doctors that will not apply that common sense factor. So I think sometimes you kind of need to give that reminder out there, whether we do it in an FAQ or whether you guys do it within a regulation to make it something that we can take action on, is something that is, you know, up to you guys.
Yeah.
It was my understanding that it had been legally requested of us as a committee that we write more specific regulations regarding IV and injection therapy based on that previous incident, and that was main impetus for these regulations.
That is correct. That is correct. We had received some communication with the San Diego District Attorney's Office and just some communications with them, and decided that we really needed to put more information in place in terms of regulations for this.
And I think we all recognize the potential danger of IV therapy, and the risk is significant compared to these very topical sorts of applications. So that, I think that's what some of us are exploring together.
Sure. And I think Dr. Yoon and Dr. Davidson both have their hands raised as well.
So one more thing regarding whether or not do we need to potentially also write regulations for people who are doing IVs outside of their office? So if they are doing like in-home IV care, would they potentially also need to have things with them that are required?
That's such an excellent point, Dr. Yoon, and actually was a concern that Dr. D'Amico brought up as well. Because of course, it's easy enough to bring, you know, epinephrine and calcium chloride with you and doing a home visit. It's going to be a little bit harder to bring your defibrillator. So I think that's a very important issue for us to assess for home care.
Yeah, I would hope that if a licensee was going and doing in-home care, that they would have everything that they would normally have at their mercy inside of their clinics, just to be prepared.
Yeah, but that would be having to be stated as well, because if you're assuming that they're going to carry a backboard with them, that's quite a lot of things that they're going to be carrying with them.
Yeah, I totally get it.
Since we're moving toward that, and I'm sure Dr. Thompson will bring us back around, but I did look up the cost of a defibrillator. It's on McKesson, it's about $1,785. And when I took CPR training last time, they tell you, they give you an app for your phone, and they tell you to identify the closest defibrillator to where you're working. And so we have one right across the street at the courthouse from my office. I talked to the police officers there. They told me where it was if I ever needed it. So we'd have it within 2 minutes. But this regulation would make me purchase one for $2,000. That's, that I'd have to have in this kit. And so just a note.
Well, it sounds like we're definitely going to have to have another subcommittee meeting on these regulations. Just fine, we want to make sure we get them right. So that would be the sort of thing we need to put together and investigate. Like, do we want to change that to say the defibrillator in the office or within, a certain distance? So that seems like the edit. Saying that okay, if there's a defibrillator that you have access to, it's just like having bathroom access, right? Like sometimes you have a bathroom within your office and sometimes you take a key and walk down the hall to use the bathroom. So as long as there's one that you have access to. So, so yeah, I mean, I think that's as well.
And another scenario besides doing it at home is like volunteering for disaster response. And one assumes that they would have these things there, like the Red Cross, for example. But if a person only did that, would they want to have this stuff in their office, even though they're not bringing it with them? You know, just another scenario to do a check on.
So are there, Dr. Davidson's had his hand up for such a long time. Sorry. To say.
Thanks. So yeah, I appreciate that. I don't want to veer us off into another direction, but it seemed as though part of what we were discussing a few moments ago made me wonder about, and again, this is a question coming from a non-ND person who just doesn't know, so maybe I'm off base here, but are there other types of IV therapies other than the ones that are specified here, which are commonly performed by naturopathic doctors and which don't need to be listed here for some reason?
I think I can answer that. So Dr. Davidson, there are two sections. There's basic IV therapy, which kind of encompasses everything else that's administered intravenously, and that is specified here. And then the advanced injection therapies are some specific additional injection therapies that listed that we as a committee thought that people needed extra training in order to do in their office. So, you know, you don't go and do ozone therapy or chelation therapy without doing a specific extra training above and beyond the basic IV therapy training. But in our current licensure, people are required to have basic IV therapy training with an approved course in order to do IV therapy in California. And that designation actually appears on the licenses of our licensees in California, that they are IV certified.
Thanks. Yeah, that is very helpful. I guess so then this is related to the decision or the recommendation to introduce the terminology, I guess, earlier in our discussion that specifically notes that this is for advanced therapies.
Well, this is actually two-part. There's clarifying and specifying what people who are doing, what naturopathic doctors who are doing IV therapy in California need to have from a health and safety standpoint in their offices. And that's the discussion we were just having about having a defibrillator, having a backboard, having an airway, having epinephrine, etc. Those things. And that was a clarification that was asked of us following an incident in San Diego several years ago. So there's that section. And then there's the section on some advanced therapies and what training we require our doctors to have if they're going to do those advanced therapies. So it's kind of a two-section regulatory package. And one of the things that's come up multiple times here is this idea that say, okay, you need this baseline stuff in order to do IV therapy. And then if you do other advanced injection therapies, you need all of that in addition to this level of training. And what Dr. Yun and Dr. D'Amico brought up, which I think is a very good point, is that microneedling doesn't, which is one of our specialized therapies that we want people to be trained in, does not require any intravenous access in order to perform it. And so do we need all of the safety stuff that we're requiring of our doctors who are doing IV therapy? That in the office, if someone is only going to do this one type of specialized injection therapy. So that's, I think, where it can get confusing as someone who's not a doctor looking at this, because there really is, it's divided up in two ways.
I see. I see. Okay, thanks. Yeah. So yeah, I understand about the requirements for what needs to be in the office as opposed to the specifics on training for particular kinds of therapies. Yeah. So I guess the main thing I was wondering about was I guess the focus that this has in in its language for the advanced injection therapies here about specialized training, additional training for advanced injection or IV therapies, as opposed to routine ones, which are covered in some other way. So we're making a distinction between advanced and routine in a sense, right?
Yes, and that distinction is only there, and Dr. Singleton, you were also on this committee, so if you have a different, opinion or interpretation, please do let me know. But that distinction was only made based on things that we believed people needed training above and beyond what they got in the basic IV therapy training. So what we were talking about earlier in this meeting was the idea that what if something else comes along that we think people need more training for, that we feel like we need to specify that training specifically? What do we do about that? And the answer was we would have to amend regulation. We wanted to add additional training. But as I was saying, there's already a provision, because we're requiring continuing education and recertification. There's already a provision for just like learning to do something new and different that's kind of within the basic IV therapy training.
I see. Great. Okay. Thank you very much. That helps a lot. Yeah. So that helps me appreciate the benefit of this particular language now.
A quick question. Is it generally understood that IVs are a type of injection therapy? Because I think we're getting a little confused in terms here, and I don't know the answer.
I mean, as opposed, I'm a little confused by the question, as opposed to what?
Well, we keep using these terms, injection therapies, including IVs, as if injection therapy is an overarching term that includes intravenous therapies. And in my mind, they've always been completely separate. IV is one thing, injection is different. Because even though technically you are putting something in a vein when you are doing an IV. So how do you guys think about this? Like, are you thinking that IVs are a type of injection therapy?
I mean, that was our interpretation when we wrote the regulations, yeah. Because it was, injecting something into the body through
Okay.
and the routes of administration differ when you do an injection. It can be an intravenous injection, it can be an intramuscular injection, it can be a subcutaneous injection, it could be an intradermal injection. We don't do spinal injections, but they exist, those sorts of things. So it's all of them are injections, it's just your route of administration that changes.
Okay.
I think maybe the easiest way to completely hit everybody's concerns would be to have another subcommittee meeting and take the 4237.3 for intravenous and injection therapy office requirements. And then the one also for training, hold on a second, and 4237.2. And what we could do is just do a separate section for IV therapy training requirements and office requirements, and then a separate section for the advanced injection therapy courses, their requirements, and for the office requirements for that, just so that we break it up and they're not lumped together. I think I'm hearing the concern is that they're lumped together and that a lot of the advanced injection therapies would not need the training requirements or for us to do would to kind of go back to the drawing board and split these two items. That way, any changes that we need for the injection therapy isn't going to hinder what we already have in place for the IV therapy. Because I think the IV therapy, the requirements and the staffing, office requirements and things, I think that is all on what we're wanting to do in the first place. So I think right now, just taking the advanced injection part out and making its own section for that, and then bringing it back all together would probably be the best course of action at this point.
Yeah, this is Dr. D'Amico. I think that would be very helpful. And there's one other thing I did communicate this to Dr. I wanted to point out when you guys look at 4237.3 is that subsection D10E says that you need to have oral and injectable diphenhydramine in the office, which is very reasonable, but we aren't currently licensed to independently prescribe injectable diphenhydramine. So if a person is doing IVs with substances that we're allowed to with independent prescription privileges and they don't have the protocol agreement with, they would not be able to fulfill this one part of the list without also having a protocol agreement. So it would be very useful for us to add diphenhydramine to our independent formulary, as it is an emergency, it's something you should have.
Yeah, so what we can do with that, because it's not something that is currently in our statute, it would have to be added to statute, which means that we could probably request something like that during our sunset review, so that we don't have to go and ask to get a bill from somebody just for an addition of the diphenhydramine. However, we currently do have it in our ability for those that are providing and administering to us. The authority was given to us in the governor's waiver for the COVID-19 shot. So that is something that is currently allowed, but once that waiver is, done and over with, then that is no longer going to be in your guys' wheelhouse. So that's something that we'll have to put onto a different agenda and maybe during sunset.
Great idea.
Yeah, and thank
So
you so much for.
Go ahead.
Thank you so much for bringing that up, Dr. D'Amico. I thought it was a really important catch because we could have basically made it illegal for 2/3 of our licensees to perform IV therapy by including that. But it's also a huge public safety issue to realize that this emergency medication is not allowed to naturopathic doctors unless they have this specific agreement. So very big public safety issue that as a committee we should try and address in our sunset. But I agree, we do need to take it out of these regulations and just make it oral. Do you have epinephrine already, correct, Rebecca?
That is correct.
So we at least have the ability to include the epinephrine in the oral diphenhydramine. But I think we do have to take the injectable out given that situation, but hopefully we'll be able to add it back.
Change because it's covered.
I didn't quite understand that, Rebecca. What?
So if you take oral and injectable out and just leave the name of the drug, once we actually get the authority to use the injectable in statute, then we would not have to come back and make the change because the name of the drug's already there, and whichever capacity that you need to use it, whether oral or injectable, would be covered by just having that name there.
Great point. I have a question. We have a specific number of doctors or composition of the subcommittee that needs to be in place for us to discuss this. Do we have to have an MD on here or anything? I'm trying to remember exactly what we need each time. I apologize.
That is, let me see, on the IV therapy, I know that we had, it was you, Osborne, and Singleton. I don't know that we had an MD on this one, did we?
Oh, that was correct. We had Dr. Osborne,
right,
specialist.
Mm-hmm.
I think we should all be available to discuss this.
Yeah, so I think what we can do today, since we do need to bring these back to the subcommittee and rework some of this, what we can do, though, is we can take some actions on a couple of the items that we were looking at, like the change of the 5-year to either a 4- or 6-year recert. That way, it's just less for us to have to do at another time.
Yeah, this is Dr. Thompson. Thank you for bringing that up, Rebecca. And so just, I know we've touched on this a couple different times, but just to clarify for everyone, we are recommending that instead of a 5-year recertification cycle, that we change that to a 6-year recertification cycle so that it lines up with our licensure, so that people can use those courses as part of their CE. We talked about doing 6 or 4. Personally, I think that a 4-year recertification is a little too short, so 6 makes more sense to me. Do other people have opinions on that?
I think I was thinking that maybe 4 years, because if there were anything that was substantially happening, then we can also address that within sunset. But I don't know if that is two completely separate things.
So just to be clear, to make sure we're talking about the same thing, that we're talking about how frequently doctors need to take the recertification courses that are part of the continuing education requirement. Is that what you were referring to?
Yes. So let's say, something happens in the field of IV therapy where there's, advanced changes. If we wait 6 years for people to get recertified and learn the new things, I think that, I don't know, things would show up in sunset review potentially that we would have to alter. But I don't know. I'm just throwing it out there. Did any of that make sense? Sorry. I'm just thinking about that in my head.
I see what you're saying.
Okay. Sorry.
But I think whether it's a 4 or 6 year, if it's 4 years, it still wouldn't give us quite enough time to bring any challenges that we may be seeing in the environment to that, because we're already on that 4-year cycle. If it was 6 years, then, things that may rear their ugly head may come to light. And we would have, a year to kind of get things in place if we were going to ask for something in sunset. But I think either 4 or 6 years would be fine. I'm just trying to look at the financial, the financial concerns that, some licensees may have on additional training and recertification. So I know that is one reason that we were talking about having it done during the CE cycle so that they can use the CE, for their requirement, to meet their requirements.
I think the question here is, of course, as a committee, we want our licensees to be as trained as possible, and that improves the public safety. But you don't want to cause an unnecessary financial burden on our licensees if it is not substantially improving the public safety. So the question is, are we going to get a significant improvement in public safety by doing the recertification at 4 years versus 6? And I don't actually know the answer to that. One of the members of the subcommittee, Dr. Osborne, who's someone who has been involved in the education of naturopathic doctors around injection and IV therapies for a couple decades, might have an opinion on that. And there are other people that we ask, but do other folks who are doing IV therapy have an opinion?
I would think it would vastly differ whether or not you're consistently doing IV therapies on a regular basis versus if you're doing them and then, 4 years later, you haven't been doing it, and then 4 years later you want to do it, right? So for 6 years, you're still doing it without having renewed anything and had any new training. So I think if you're talking about somebody maybe like yourself who does IV therapies pretty often, recertifying doesn't make sense within 4 years. But if you're talking about somebody maybe like me who's done the training last year and I don't expect to do too many IV therapies, I would think that 4 years would be perfect.
I think there's a level of clinical judgment that, as any health professional, we all have to take assessment of our skills and whether or not we have what we need to do that. And, that we have to trust that people have that at some level because we can't regulate good judgment, unfortunately. I'm okay with 6, unless there's a good reason to change it to be shorter that we know of, and we can always change it if we need to. And
sorry.
I was going to say, and I'm assuming that, but I'm open to whatever. And I'm assuming that when the subcommittee reconvenes, they're going to look at the recertification requirement separately for IV therapy from the advanced injection therapies. And I say that because, if you're doing these injection therapies, especially because they're so specific and it doesn't involve a potentially limitless number of compounds that you're using or techniques, that, once you know how to do microneedling, there's not much more you're going to learn every 4 years or every 6 years. So anyway, I invite you to just consider them separately.
Yeah, I definitely think it's clear that we need to look at those requirements separately. I just wanted to point out, as far as the recertification for basic IV therapy, that kind of the point of that recertification, and when we put in the information, we specified that that was going to be a shorter course than the original course people take for IV therapy. So the purpose of that recertification course is not really to remind people how to do IVs. And I absolutely hear the benefit of doing continuing education, especially if you feel like you're not as, you don't remember as well a certain procedure or something because you haven't done it as frequently. We've all been there where we're like, well, I learned that in school, but now I have to, get the education and relearn it in order to practice it safely. But the main purpose of the recertification is to cover anything new or different that has come up. So I think not so much to help people who, you know, and perhaps I'm wrong with this, but not so much to help people remember how to do the basic things, but more to say, okay, these are the things that are new and different that we've learned. And so then the question becomes, how often do people need to do that? And how quickly are things changing? So are we, it doesn't sound like we're really prepared to make a decision on that either. Becca, I know we're hoping to get that, completed in this meeting, but it does sound like we're going to have to look at that as part of the subcommittee reconvening as well.
Sure, that's understandable. Okay, well, in that case, I don't think that we have anything left.
This is,
for,
sorry, I
Go
had
ahead.
one other thing just for the subcommittee on ozone. In number 5, section C, it's pretty clear to me that, saline with ozone is allowed, direct injection of ozone is not. And do we want to say without it being combined with a liquid or make it even more specific?
We can definitely work on that language to make it very, very clear that we are basically specifying that you can't directly inject the gas into the venous system. So we can try to clarify that language.
Great, thanks.
So one more thing is I don't want to be the holdup for 4 or 6 either. And I'm thinking about whether or not, if you are on a 2-year cycle to do continuing education, if you are going to finish the continuing education prior to your second second licensing renewal, then it does make more sense to have it as 6 because that would be a shorter period of time in between, I think, renewal. Does that make sense?
Yeah, so if I understand you correctly, you're saying that you're going to potentially complete the CE before the licensure cycle ends. So so that it doesn't, it may end up being less than 6 years in that situation, like 5.5. The other thing to keep in mind is that our licensees always have the option of taking these recertification classes closer together if they feel the personal need for that education. We're not saying we will only give you CE every 6
Exactly.
years. If you want to take these classes every 2 years, you'll still get continuing education credit for it. And that's fine. So that's something that, people always have the option to do. I think we're saying, in most regulations, we're kind of saying this is the minimum for public safety.
Right, right. And I agree with you on that. But I'm also thinking that when you do the recertification, you always consider the fact that it's also continuing education, right? So what do I have to do in this allotted time period to be, one, recertified, but two, also get the continuing education requirements?
Absolutely.
So I think we are agreeing on 6 years, correct?
Does anybody disagree with a 6-year recertification cycle specifically for IV therapy? Rebecca, do we need a roll call vote on that, or are we just moving forward?
I think let's just go ahead and take it as a recommendation for the 6. It sounds like we're all pretty much in agreement, but I'm not ready to take any action on any of this right now. It's just not ready. And that's fine. What we can do is I'm going to put down that it looks like IV therapy recertification is okay at 6 years with everybody on the line right now. So when we go back for the change in this language, we will go ahead and put 6 years for the IV therapy. It sounds like there might be some concerns still with the advanced injection therapy being 4 or 6. So that's something that we'll take a look at when we reconvene as a subcommittee. If there are any issues or concerns in the meantime from any of the non-subcommittee members, please make sure that you send that my way so that I can compile that and take it to the subcommittee at the next meeting so that we can get these, this language edited and created and brought back to you.
And do we need to schedule that subcommittee here when we do that separately?
I'll go ahead and just send a doodle out for the subcommittee members, and we'll get that done relatively quick.
I had one other small little formatting thing under the training requirements, 4237.2. The section B is for advanced injection therapies in this section, which is IV. And then it lists in subsection 1 for the use of certain IV chelating agents. Oh, never mind. I was kind of confused if number 2 was a subsection of 1 or if it's a subsection of B.
It's a subsection of B.
Got it. Okay. Because so subsection 1 is in addition to what's in subsection 2.
Correct.
Yeah. I might suggest that we put the one that's in 2 first and then put the one that's in 1 after it so that it's clear, like, here's the basic. And then if you're going to do this other advanced stuff, then add this on top just as a flow of information.
At this point, I'm going to ask for any additional comments or concerns by the committee members.
This is Dr. Singleton. I have a quick comment or needing clarification. So with respect, and this is regarding the advanced injection therapies, just something that we can also bring to the table and consider. In terms of number 1, I think we're going to talk about the amount of time for the recertification process, and also in terms of the providers for accredited providers, or sorry, approved providers. And the other thing too is the grandfathering process. So if people have taken either PRP or advanced injection therapy, like what is the time frame that they would have to adhere to the new regulation? like would they be grandfathered in, or would they have to, on their next licensure renewal, then prove that they had the advanced injection course? I'm not sure that we talked about that. I don't remember, but just something that we can add in for discussion.
I think we did discuss some sort of a grace period to allow people to come into compliance, but that should be really specific in here so it's not ambiguous. I totally agree. Because we don't want someone who's already doing a therapy safely to have to stop doing it for 8 months while we come up with a CE provider who can train them. Like that's the situation we're trying to avoid with that.
Mm-hmm.
And I don't know that we need to come up with any CE providers as long as the CE providers meet our statute with the already authorized providers that are, or approved CE providers that are listed in our statute.
Sure, okay.
I think the concern is that for a couple of specialized therapies, that is something that is going to and that hasn't happened yet because the regulatory package hasn't come through, so we haven't had people apply to be providers. So dealing with that potential time lag.
Okay.
Okay.
So at this point, I'd like to call for public comment. Moderator?
And the public comment feature in WebEx is available. And let's see, we do have 2 questions already, but I'm going to also open it up for more. If you click on the icon with a question mark within a square located at the bottom right-hand corner of your WebEx screen, you can, in the Ask field, type comment, or I would like to make a comment, and send to all panelists. Each respondent will have 3 minutes to make their comments, and I will provide a 30-second warning. And we will take the comments in the order received. Our first comment, I believe, is from Dr. Shannon Wood Gallegos. And let me go ahead and send her the unmute instructions. And Dr. Gallegos, you're welcome to make your comment.
Yeah, I guess, I mean, some of my questions were answered just in terms of why this has come about in the first place. You know, for those of us who are doing this work, I guess I'm getting hung up on the word recertification, because when you've been doing this work so long and it's already such limited resources to be able to get IV training for many people, I just don't understand. It's like we're making it even harder. We're shooting ourselves in the foot. And I completely understand the requirements for always keeping yourself up to date on the IV nutrient training. I think that's so imperative. But why can't we just require it in our CEs? You know, if you're IV certified, you can take, you know, you have to be required to make so many CEs, and it has to cover all of these variable factors. You know, I want to know what other practitioners, are there nurse practitioners, are there RNs, are there, you know, DOs, are there MDs that have to do recertifications for IV and IM injections? It's just ludicrous to me, to be honest with you. And I think it's taking our profession and setting it back. I completely agree with the continuing education and making sure that everybody is up to date. But I don't understand how we're getting set to this standard when you know, other practitioners it's not required of them. So maybe I'm missing something in the original research around how this was brought up. So I'm not trying to say we don't need continuing education around it, but I think the word recertification is where I'm getting hung up. Also, throughout the recertification, it talks about the ACLS certification. And traditionally ACLS certification, you have to push meds. And, you know, unless you have an overseeing MD or DO, we cannot push meds. And so once again, I foresee that being a huge hiccup in this training requirement for the certification, for the recertification of the intravenous therapies. Also, my third point is that we don't even have enough people right now to train our new practitioners coming out to do IV nutrient therapy. And so I know Virginia and her team, have done a great job. I took her certification, I took her classes, I continue to do her advanced trainings. But, who else can we quickly bring up to speed who's been doing this work?
30 seconds.
Classes. So I'm just a little upset that, not more people are chiming in. I'm going to put together a group of individuals who do this work regularly, and that way we can send Rebecca some information before our next meeting.
And I have no other comments at this time. Shall I close the Q&A feature?
Yes. I'm so sorry. We don't generally get many public comments. So are we supposed to respond to those or simply take those as information?
This is Sabina. Can you hear me?
Yes.
And thank you.
Okay. You can go ahead and answer some of to clarify some of those questions if you would like.
First of all, thank you so much for joining, and your input is extremely valuable to us. As a committee, we do our best to protect the public and also make sure that, naturopathic doctors are being supervised but not, unduly burdened in any way. And so having the active naturopathic doctors comment and share their experience with us is very, very important to us. And I look forward to getting your information. I would say that I think that we're getting hung up on semantics as far as the continued training, and we could certainly move the term recertification and simply add it as a CE requirement in the same way that several hours of CE are required every 2 years for pharmacology for naturopathic doctors in California. But just to reiterate what I said earlier, the idea of what we were calling the recertification here was never meant to retrain people how to mix basic IVs or insert a catheter or anything like that. It was to keep people up to date on the newest research and information for this therapy, which has a higher level of risk than certain other therapies we're doing in the same way that pharmacology does. So we can definitely look at the semantics on that and see if a change in wording would definitely be interested in your input.
Dr. Thompson, this is Dr. D'Amico. I think it was also mentioned in our meeting that new graduates will already have the basic IV training. So they would only need the additional training for these specific advanced therapies if they're going to do them coming out of school, correct?
Currently there's only 2 schools, Bastyr and NUNM, that offer the IV therapy that have met our requirements. There may be some other schools. They have not sent their information to us. We've requested their information on their courses to see if they do meet our criteria, and they have not done so. So currently, those are the only 2 schools that we know of that we will identify and take the IV therapy from them. So it wouldn't be all graduates.
Yeah, and just to clarify, this package that we're talking about does not change the basic IV therapy requirements that are already in place in California. That's the initial certification, the initial training is already in place. We're talking about moving forward as people, as licensees practice, how often do they need to do sort of a brush up course? And we did specify we're not requiring people to go back and do the initial training again, which, if I remember correctly, is 3 days long. We were talking about a CE requirement that was significantly shorter than that on a 6-year rotation. All right, are there any further comments on that from members of the committee? Dr. Yoon.
Sorry, I think I was leaning on the bar, but I actually do have a comment. Maybe the subcommittee can also consider whether or not for so-called in quotes the recertification can be also considered instead of having that continuing education, having a certain amount of clocked hours working with IV therapies.
I think that, again, the point wasn't the level of experience or day-to-day exposure so much as it was keeping up with any changes or new information about about IV therapy and new nutrients and new injectables and things like that.
Right.
Got it.
Also, I did want to also touch on the idea of having to push meds as part of the basic ACLS training. And yes, we're definitely looking at that along with the diphenhydramine and making sure that we don't require anything of our licensees that they're not legally allowed to do. Super important for us to be clear on.
Are those items that we would be required to use in an ACLS situation? Could we consider, referring that into that subject along with the diphenhydramine?
I think it's a great idea. I mean, I think if our purpose is public safety, then it's a significant issue if naturopathic doctors are not able to perform emergency medical care.
Maybe people are aware, I think dopamine is one of the things I believe to do without supervision.
So I think that's actually, I think it's an important topic that's come up in this meeting, but we should probably reserve that for our sunset meeting, which is coming pretty soon.
Okay.
Any other comments from members of the committee? All right. And hearing none, Rebecca, do we have anything else to cover prior to adjourning today?
No, that was it. I just want to remind the party that is on the line in attendance today. If you do have anything that you want to bring to the subcommittee's attention, please go ahead. We will have the contact information on the next screen. And you can go ahead and email that directly to myself.
Thank you, everyone. Thank you, Rebecca, for everything you do. And thank you, everyone, for taking time out of your day to join this meeting. At this point, I'm going to adjourn the August 30th, 2021 special meeting of the Naturopathic Medical Committee. It is 10:44 a.m.